call the next speaker, Dr. Shweta, who will present on idiopathic epiretinal membrane and its novel association with hyperreflective foci.
Good morning, everyone. I am Dr. Shweta Suryakan, and I am presenting a paper titled Idiopathic Epiretinal Membrane and its Novel Association with Hyperreflective Foci. So, how did this idea come up? We had a 65-year-old male patient with a nuclear sclerosis grade 2 with an idiopathic epiretinal membrane with a BCVA of 612 N12. So, this was his pre-op OCT picture, and he had a central macular thickness of 335 microns. He underwent an uneventful combined surgery phaco-IOL with vitrectomy ERM peeling. As you can see, the pre and post-op OCT anatomically looks good. The membrane is well peeled, all good, but not really. We see that the central macular thickness increased from 335 microns to 367 microns. Also, the BCVA dropped by one line. So this led to a lot of commotion. In spite of doing a good surgery, if the patient has a drop in vision, there should be some other factor which is playing a role. So we went back to the OCT, and on some keen observation, we found these tiny hyperreflective foci in the OCT, which was not really a described feature in ERM. So we went back to many other OCTs of different patients with epiretinal membrane, idiopathic ERMs, and we found similar findings in many of these OCTs. So this led to the study, the novel association of hyperreflective foci with idiopathic epiretinal membrane. So we did a retrospective study between Jan 2018 and Jan 2020. We chose patients who underwent surgery for idiopathic ERM. Some of them had received steroids, some did not. It was at the surgeon's discretion, and we wanted at least follow-up of 1 month to be included into the study. So all OCTs were done on Swepsos OCT, Topcon DRI OCT Triton Plus. Radial scan 12 into 12 mm centered on macula was what we do. And all OCTs had a minimum sound to noise ratio of at least 35, and all the images were independently graded by 2 observers, and then it was tabulated. We used the Govetto classification to grade the ERM. Stage 1, there was negligible disruption of retinal layers. Stage 2, if there is stretching of the outer retinal layers. Stage 3, if the ectopic inner foveal layers are crossing the central fovea. And stage 4, where there is complete disorganization of macular anatomy. A statistical analysis was done. A p-value of less than 0.05 was considered as statistically significant. We had 13 male patients and 11 female patients in our study. We had 5 patients each in stage 2 and stage 4 groups, and maximum of 14 patients in stage 3. We saw that the mean hyperreflective foci increased as we went up the stage. Also, the mean central macular thickness went up as we went up the stage. So the number of hyperreflective foci was a mean of about 4.2 in stage 2, and it increased to a whopping 59.2 in stage 4. Also, the central macular thickness corresponded accordingly, and both of these values were significant statistically. So let's see 2 cases now. The first case is a patient of stage 2 ERM, where the central macular thickness pre-op was 304 and increased to 332 after an uneventful phaco-IOL with vitrectomy and ERM peeling. And this is another patient of a stage 4 ERM, where the central macular thickness decreased from 554 to 448 microns. The key difference here is that the second patient also received an intravitreal dexamethasone implant. So when we compared the 2 groups, those patients who received steroids and those who did not, those who received steroids had a better resolution of the macular thickness. So these patients reduced from 372 to 283 with 372 to 313 within a month, while in the group without steroid it in fact increased. When we do a head-to-head comparison, the hyperreflective foci also decreased significantly at 1 month, and it shows a very steep drop by 3 months of post-operative period between the group with and without steroid. So what are we really trying to prove here? See, there is one study which speaks about hyperreflective foci in idiopathic ERM, but they do not describe the clinical relevance of the feature. There are few studies which advocate the use of steroids in epiretinal membrane surgery, but they do not have a strong rationale to support this use. There are few papers which speak about the role of inflammation in ERM, but again it is not proven. So our study is connecting the dots. So we now can postulate that there is a role of inflammation in idiopathic epiretinal membrane, which is represented by the hyperreflective foci. Hence, steroids do better. Patients with steroids do better. So, what to do for the subclinical inflammation? Firstly, we have to look for these hyperreflective foci in the idiopathic epiretinal membrane cases. Look for macular thickening. If both these indications are present, we suggest use of intravitreal steroids, especially if the ERM is stage 3 or 4. So that way you have a better central macular thickness resolution, better BCVA, and a happy patient. Thank you so much.
Nice
Thank you,
present.
Shweta. That was a very nice, interesting paper. Only one thing I wanted to ask you is that in your subgroup of patients, were there any diabetics?
No, ma'am, no uncontrolled diabetics. And we did not have any patients with diabetic retinopathy.
Okay.
You have started your paper because the central macular thickness increase in the post-op period.
Yes.
When have you taken that increased central macular thickness? 1 month, 2 months, 6 months, 8 months?
The first image that I spoke was 3 months later, sir.
How much time it will take to normalize the macula after the ERM surgery?
Sir, by one, there will be some manipulation.
No. I am asking how much time it will take the macula to normalize after the ERM surgery.
Sir, it should come back to somewhat normalcy by 1 month. By 3 months, I think post-op edema should have subsided.
More than 6 months it will take.
Okay.
More than 6 months it will take. So your first is you have started the thickness has increased, and the thickness increased from 300 to 332. Some other person is taking the OCT, you are taking some other scan. If you are not at that point, you will find n numbers of variation.
Yes.
So this 32, it's negligible. And the hyperreflective foci, because you are inducing the trauma in the eye, plant trauma, which is causing the inflammation, that is increasing the central macular thickness, if at all it is increasing. But it will resolve. That's why we are giving the prednisolone after the surgery.
Sir, all the other patients who did not receive steroids also received
I'm not
prednisone.
I'm talking after the surgery you are giving.
Okay. Yes, that's
You
the
are
reason we
giving
give
the
topical
steroids or not?
steroids. Yes, sir, we are giving.
That is because we are controlling the inflammation, which is because
Surgically
of the plant
induced
trauma.
inflammation. Yes, sir. Yes,
Okay.
sir. Agreed, sir.
And what he rightly said is that you didn't have about a 50 microns difference between the CMT previously and when you started the treatment. So the thing is that you have to have a sizable amount of edema to justify starting your treatment,
Yes, ma'am. Yes, ma'am.